to make sure that we check in with Paul Seegert as well, because I am personally intrigued by this idea that hospitals are able to charge so much more because of the existence of private insurers. So let's see if I even frame that correctly. Paul, how are you doing today?
I'm doing great. Thank you for having me.
Oh, I appreciate you joining us. Folks, Paul comes with some expertise. He works with an organization that does health insurance advisory work, so he knows both sides of the industry, the health insurance side, the hospital administrative, the public service side of it. Paul, this recent study saying that 224% more charged to private insurance than to Medicare. What does that even mean? What are we looking at in terms of dollar figures? And can we call this overcharging?
Well, you've got some overcharging going on in the system and some undercharging. And this is an average. You may have some, and it varies by state. If you were in Indiana, as an example, we could add another 100 points on top of the 224. And depending on the exact health plan and the size of the plan and so on, it can vary. It can be 3.5 times Medicare that they get charged. In some states, it might even be 10 times, depending on the payer. So there's a huge variation. It's something we should talk more about because it's a rather convoluted system that we have. But you have two things going on. One is that hospitals may actually lose money on a transaction if a Medicaid or Medicare patient shows up, but tolerate it because they intend to overcharge other payers to kind of make up the gap.
Wow.
They need 120 to 140% of what they collect on a lot of transactions from these Medicare and Medicaid payers, and so then they turn around and overcharge. I think it's a fair word. Employer plans. So employer plans are subsidizing maybe the opposite of what people would think is happening in the system in terms of who's subsidizing who. But employer plans have become the source of profits for this part of the industry.
Wow, because they're looking. They need to they need to meet a certain threshold to make a certain amount of profit. Is this about? Is this because hospitals are ultimately profit-making endeavors?
Absolutely, absolutely. That plays into it, and they're not eager to broadcast to the world that they have as many as 150 different prices for every procedure they perform. This transparency rule that we've seen in and out of the media recently, where hospitals are supposed to publish their pricing for 300 common procedures, was actually part of the original Affordable Care Act, and I think a very good part. If people ask me all the time, what would fix the high cost of health care, in one word, I would say transparency. And there's a lot more to it, but that's the starting place. And hospital associations fought that part of the Affordable Care Act in the courts for 11 years. Finally, it did get implemented, but in implementation, the fines were so minimal, $300 a day, when a mid-sized hospital could be running north of $10 billion a year. $300 a day is just truly insignificant.
So wait, what was the transparency supposed to look like?
Well, in theory, what we're supposed to have is you should be able to log on the internet. You might need a procedure. 85% of procedures are scheduled. So throw out the 15% that are emergencies, where you just need to get to wherever you're going as quick as you can. But the other 85%, in theory, you would be able to go on and see, okay, if I go to this hospital, my hernia repair will be this much. If I go to this hospital, it will be that much. And do some shopping. And we could start to get that powerful force, the American consumer, working toward giving them some better information so they could consume healthcare better. And with the way plans have evolved, significant out-of-pocket costs that many of us have when we seek care, I think there would be some motivation on the part of consumers to...
Absolutely. I mean, listen, I'm a very good Google monkey when it comes to shopping and price comparison, and I love me some grocery store coupons. Absolutely. I'd be like, oh, that one over there? Oh, that one over there? Right. But is it also... my premium is my premium, right? The rest of it gets taken care of in some magical mystery bureaucracy of health insurance companies. So Yes, am I even incentivized really to comparison shop? Right? Because it's not going to affect my bottom line. That's going to change. The insurance company is still going to be making their profit. So why do I care if the insurance company hospitals are overcharging private insurance?
Yeah, well, exactly. That's a problem we have with the model that we have as it stands today. We don't give consumers good information to consume, and we don't reward them when they consume well in the way that their experience works. It's very similar to what we're seeing right now with the part of this legislation that's going through Congress right now will put a cap on the co-pays for insulin at $35. That's a good thing. What they're not addressing is the very high overall cost of insulin. So we're looking at that member level saying, hey, you're only going to pay $35, but we're going to allow the insurance payment model to continue to overcharge your plan, which will get baked into your future premium increases.
That's right.
So
that's where it ends up hitting
consumers.
Because they will figure out a way to pass on, right? Pass on any of that pain. So because again, it's a profit generated or profit motive industry built on the backs of actual public service needs, right? Nurses, doctors, not the ones making tons of money, genuinely going into these industries to, yes, you want to make a good money, but you're also doing this for service. Where is there room then for consumers to take more action to just stop the waste, right? Like that just seems like these reinforcing systems really aren't helping consumers. Somebody else is profiting off of the fact that I need to go into the hospital, right? Like that still doesn't sit right with me. So where is there room for me as a consumer to do something about that?
Well, we do have our share of costs as a consumer. So many of us have high deductible plans. Maybe we have an HSA plan where we have a part that we're responsible for, and it's a significant part. This year, max out-of-pockets for an individual can be as high as $9,100 as we head into this renewal season. That's a big share of cost. So it will reward us to consume better, but we still don't have the information. We need to get the information in consumers' hands. I was looking recently. This transparency rule is now the law of the land. And as of this moment, while you and I are talking, 0.5% of hospitals in the three largest chains are actually fully complying because it needs more teeth.
Yeah.
It went from a $300 a day fine to a $2 million annual max, and it's only going to apply to 2 hospitals in this whole country, and we have 4,000. Certainly, many of them are out of compliance and have made no effort to comply, or very little. And it has to be enforced if we're going to get there.
We're talking with Paul Seegert, who is an expert in health insurance, hospitals. He runs a consulting company that deals with many of these challenges. In your conversations with clients in the healthcare industry, what do they see as the number one problem affecting access to quality healthcare? Is it prices?
We do have costs. The cost is absolutely an issue. You have people delaying care, which has gotten worse just because of general difficulty out there with inflation and so on. 1 in 4, the recent poll I was studying, 1 in 4 have delayed care or have had to cut back in other areas to even afford their share of cost because of the size of the co-pays, deductibles, co-insurance, and all these different words that we've come up with to shift cost to consumers. It's a serious issue that we don't talk enough about. Many, many, many billions and billions of dollars in medical debt out there held by insured Americans. And one thing we're doing to address it here recently is that the credit bureaus have come out and said, hey, we're going to stop reporting it in the same way. So that's nice. That helps these consumers, but let's actually solve the problem as to why it's so overpriced, where they don't get into this situation and give them good information to consume. There is some positive, optimistic stuff going on out there. There are employers who, in more and more cases, who are engaging with consultants and advisors that will assist them in uncovering some of this waste, improving the contracting that they have with the healthcare providers out there, the community out there, eliminating the waste that's attached to the cost of drugs. There really isn't any good reason why we should represent, as American consumers, a few hundred million of 80 or 85% of global profits for that part of the business.
Right.
And the reasons they give as to needing to fund R&D don't hold up that well when you see that many of those dollars, a huge portion of the dollars, go to middle players that don't make drugs. They don't do R&D. They don't engage in that business. So there's a lot of work to do.
As I mentioned, Paul helps run an organization, a healthcare benefits consulting firm. It's called PCS Advisors, based in Northern California. The study that we were talking about does list some states. California happens to not be one of them, but some states where the costs are especially out of control when it comes to what's being paid to private insurers compared to Medicaid. Florida, West Virginia, and South Carolina had prices that were even higher than 310% of Medicare. Hawaii, Arkansas, and Washington paid less than 175% of Medicare rates. Is this part of why we see in these states that, and these are states with high, like Florida, West Virginia, South Carolina, they have high senior citizen populations. Is this why we're seeing a challenge of doctors accepting Medicare? Is because it's just not enough to cover their share of the burden?
Exactly. And then where you have a marketplace or a subsector or a geographic area where there's a heavy, if you then took these states and said how many of these folks are on Medicaid or Medicare, you're going to see a correlation there. You're going to have higher percentages of their population, so then their providers, the hospitals, are more upside down in simple terms and need to shift more cost to employers, employer plans, to make up the balance.
Wow. That's a lot. It already costs so much to give birth in the United States, just like things that are necessary for the survival of humanity that we have to pay for. And if you don't put your child, your baby, on your insurance immediately after they are born, you can end up paying for the birth of that baby, depending on your insurance, even if you pay the out-of-pocket costs, even if you have insurance. And these tiny little bureaucratic things can have massive consequences. And yes, we had one of those insurance plans where my husband, as soon as the baby was born, called them and be like, add the baby's born, we need the next 3 days covered. It is what it is. A quick question I have for you, Paul, coming from one of our callers, Brad in Iowa. Brad, what is your question for Paul?
Hey, guys. Okay, Paul, can you explain maybe how this impacts how we should look at which plans we choose for our insurance? So, for instance, we chose this year a high deductible plan because our company offered, a nice chunk. But if we're paying 2 to 3 times, let's say they submit 3 times what it should be worth, and the insurance company 2 times, we're still paying way more. And I feel like it just eats through, that high deductible, the whole point of the high deductible, versus if you just go back to maybe a flat rate and you try to, can you explain how that impacts the consumer and maybe how we should think about how we choose our insurance based on these figures?
Sure. That's a great question. I think at a high level, what you have to do is make your own cost-benefit analysis, and you're going to have to take some degree of risk in that because you're going to have to, there's a little bit of guesswork because emergencies can be expensive. But generally the advice that we give is that if you're not someone dealing with chronic health issues, then that high deductible health plan could make sense because you are going to push your fixed cost down, your monthly premium down. And then maybe you take a portion of the difference and put some away for a rainy day. Maybe it's an HSA qualified plan and you put some away for a rainy day. And you're ready then when that unforeseen event happens. Someone breaks, I have a handful of children, and my son broke his arm in the last week of the summer. And now we're through our share of costs for the year. I couldn't foresee it, but we had put some away, fortunately, where we were able to use that for that purpose.
Paul, appreciate you answering our caller question. Do you see anything moving legislatively in Congress right now? Has anything even been proposed to to put a check on private insurance companies charging so much?
Well, a lot of this happens. We have so many unintended consequences in the system. The legislation that we have going through right now that is going to allow Medicare to negotiate drug pricing, I think does have the potential for some further unintended consequences that shift costs to employer plans on the drug side of the business. Mm-hmm. So far, we've been talking about how that occurs with how hospitals are charging different payers very different amounts to make their profit margin goals that they have in mind. And on the drug side, if we get to a place, which it looks like we're heading that direction, where Medicare is able to pay a significantly lower amount for, at this point, we're going to start with 10 or 20 high-dollar drugs. We have the potential of pushing that balloon again and watching those costs show up in the employer health plans and their drug costs. So that's a concern that I have right now. And
you're talking about a concern coming out of the Inflation Reduction Act, right? That the White House has been talking about, the negotiation for Medicare prescription drugs.
Right.
Oh boy. Well, that's, as you said, this is the result of the convoluted system that we have. For those who have recently traveled to Europe, it is, you land and you just get in a car and you look around and realize that not a single one of the people around you has to even worry or think about showing up to a hospital and what that would mean for any care, life-saving, regular checkup. It's just not something they have to think about. And so, that is possible somewhere in the world, to just not have to worry about healthcare costs and the decisions you have to make as a family. Paul, appreciate you joining us, and thanks for getting into the details and taking questions on, what's going on with hospital pricing and private health insurance. We were talking with Paul Seegert. As I mentioned, Paul is a managing partner at PCS Advisors. They're a healthcare benefits consulting firm based in California. They tweet at PCS Advisors, and we were discussing the study about hospital prices skyrocketing. It's a Rand Corporation study. Paul, thank you for joining us.